Okay, thank you very much for joining us for this symposium, Diagnosis and Treatment. I'm Michael Breakspear. I'm a psychiatrist on the lands of the Awabakal people, and I'd like to acknowledge the Eora people of the Gadigal Nation and pay my respects to their elders past, present and emerging, and acknowledge that the land we're meeting on was never ceded. We have 4 speakers today, and they've been instructed to give precise 8-minute talks, but they're trying to negotiate a little bit of wriggle room. If we don't have time after each talk for questions, there might be a bit of time at the end, and if they go over time, they've volunteered to give you their mobile phone number so you can ask them questions later on. I'm very delighted to introduce the first speaker, born in Adelaide, off to Cambridge and then Berkeley, and now I'm very happy to be co-supervising him with Bill Jagust from Berkeley. And Joe's going to showcase some of the wonderful work on diagnostic entities in the complex biological data that we acquire. Thank you, Joe.
Is it possible to turn this to like the other view so it's not in presenter mode? Yeah, perfect. Now, can I go backwards? Yes. Okay, thank you. Yeah, thanks, Michael. I'm Giorgio. I'm a research scientist at UC Berkeley. Today I'm going to present the work of my grad student in Berkeley, Marcel, and he's developed an approach to synthesize tau PET from MRI. Tau PET's a very powerful tool in Alzheimer's diagnostics. The topography of tau PET closely follows the underlying neuropathological stage of tau. What's more is the topography of tau PET can predict incidence into dementia. So the more advanced stage of tau PET is much more likely to advance to dementia in a near future. What's more, and quite timely, is tau PET is also predictive of response to monoclonal antibodies. So this is data from the donanemab trial where the participants who had high tau PET at baseline did not respond to the treatment. Now, there's plenty of constraints with tau PET. It's expensive, it's hard to manufacture, and that really makes it infeasible to collect in most clinical settings. MRI, in contrast, is much more readily available. It's cheaper, and also from a research perspective, there's decades of archival data, so you can start to look retrospectively at clinical trials. So our task was to make MRI look, feel, and act like tau PET. Previous deep learning approaches to this have produced pretty poor results with weak association between synthetic and ground truth data, and that could just be because tau PET and MRI aren't that closely related to each other. Except what's known is when you include with MRI covariate information, you can improve predictions of Alzheimer's pathology. But of course, having complete covariates is unrealistic, so you also want to have flexibility to handle missingness if you're trying to solve this problem. So this is how we did it, and I'm going to go in zero technical detail about how it's done, but really isolate what goes in and what comes out. The outcome of this model is a 3-dimensional synthetic tau PET scan. The input is a 3-dimensional T1 weighted MRI and available covariates. And we selected from what we thought would be feasibly collectible covariates, and they come from demographics, vital signs, genetics, and plasma. Now, a really important feature of this model is the first step is to impute in missing data in the covariate set. So that means you can generate this image with some, none, or any, or all of these covariates as long as you have an MRI available. In this project, we used 6 non-overlapping samples from 3 parent cohorts. We built the model on ADNI-A4 data, who are predominantly clinically unimpaired, and then we did validation in samples from the ADNI, A4, and the NAC. Now, important features in these data, the NAC scan data set had 2 traces available, so we could check the association between different traces in the synthetic image. And the NAC non-scan data, these are very noisy T1 weighted images, so a very heterogeneous setting to perform these predictions. And also there's varying degrees of plasma available across these samples. So how well does the synthetic image track the ground truth image? This is an example learning curve from one of our crossfolds, and the important feature here is to see that that curve is increasing. The value of each dot shows a correlation between the synthetic image in a region of interest and the ground truth value of that same region of interest. At the end of training, you can see performance. You get correlations between the ground truth and synthetic image above 0.6, exceeding current benchmarks. And when we look across all of our internal folds, we reproduce this good learning performance, and we see at the end of training, we can predict correlations about 0.5. So then we performed a validation out of sample, and this is in the NAC data set, and there's 0 plasma involved in this synthesis. What you can see here is a scatter plot showing the predicted value on the x-axis, so the synthetic tau PET in a region of interest, and the ground truth value in the y-axis. And you see again correlations about 0.5. Now, an important feature here is when we look at the association between the predicted signal and the ground truth flataucipere PET signal, shown in blue, or the ground truth MK6240 tau PET signal, shown in green, you get the same association. So your model's not just predicting flataucipere, which it was built on, but can also predict underlying tau PET across multiple traces. So next we ask a much more biologically relevant question, that is, do these synthetic tau PET images track with the underlying neuropathological stage? Seminal work by Braak and Braak set out how tau spreads across the cortex, defined by neuropathology. The first stage, stage 1-2, tau is really restricted in the medial temporal lobe. Stage 3-4, you now see tau moving across limbic structures. And then stage 5-6, you now see involvement of the whole neocortex. Critically, tau PET covers these different stages and aligns with the underlying neuropathology. So what I'm going to show here is in another held-out sample from ADNI, who had neuropathological Braak staging available and antemortem MRI, how these synthetic images track the neuropathology. We're going to look first at 3 example images, or synthetic tau PET images, based on different neuropathological stages. This is the result, or a synthetic PET image for a participant who was Braak stage 1-2 at autopsy. You see low level, really mainly restricted in the temporal regions. This is a participant who was Braak stage 3-4 at autopsy, higher signal spread out in lateral temporal regions. This is a participant who was Braak stage 5-6 at autopsy, much higher signal in posteromedial cortex, and now involvement of the frontal regions. When we perform the group-wise contrast between adjacent Braak stages, again defined by neuropathology, you can see the synthetic tau PET is spreading in the stereotypical pattern, where with increasing Braak stage, you see greater involvement across the neocortex at higher levels. Next, we perform this validation in a much harder sample. So this NAC non-scan data set has very noisy T1, very heterogeneous, and no plasma in the synthesis. Again, stepping through 3 example cases. You see here Braak stage 1-2, relatively lower signal to this Braak stage 3-4 participant defined at autopsy. And here again, a Braak stage 5-6 participant, much higher signal spreading out into the frontal regions. And as with ADNI, when we do these group-wise contrasts, you see this topographical spread in the synthetic tau PET signal that mirrors the underlying neuropathological stage. So really we can see here in heterogeneous settings, you can capture with this synthetic tau PET image derived from MRI, the underlying neuropathological burden of tau. Finally, we assess the association between the synthetic tau PET image and cognition, both cross-sectionally and prospectively. Here we have group-wise contrast of the synthetic tau PET image by clinical diagnoses, and you can see that there's an increased level of synthetic tau PET in patients with dementia, which you can see in the brain map on the left, with great involvement of the lateral temporal lobes and posteromedial cortex. Then what we did is we extracted out the average signal from the synthetic image in the JAK metatemporal region of interest, which is shown in the right, and diagnosed the different classes, so the different diagnosis. And you can see the ROC curve shows good diagnostic performance using this single measure from the tau PET scan. Next, we associated that same measure, the synthetic JAK metatemporal region of interest, with individual variability in cognition. So this middle scatter plot shows the relationship between synthetic tau PET and MMSE, and then the plot on the left shows the association between the ground truth tau PET and MMSE in exactly the same people. Now these associations are not different from each other, showing that you can actually generate the same association with cognition across synthetic and ground truth data. This was also reflected on the brain map. So if we just look at the voxel-wise association or correlation with MMSE, we see strong correlations, really in rare areas that you would expect. So this is our final validation. And what we wanted to know is, based on baseline synthetic tau PET, can we make predictions about prospective cognitive decline in asymptomatic people? So this is data from the A4 clinical trial. We generated the synthetic tau PET image at their baseline visit. We extracted out the average signal from the JAK metatemporal region of interest and bin that into tertiles. So here, the blue tertile, or the blue line, shows the highest synthetic tau PET at baseline, and the red shows the lowest synthetic tau PET at baseline. And you see here that you can find deviating trajectories based on these synthetic images. Critically, we could do this with and without plasma data when we did the synthesis. So to summarize, we put forward a novel approach to generate synthetic tau PET with MRI plus covariates. This was highly generalizable across different traces and cohorts, and it faithfully tracked the underlying neuropathology. Really interesting from my perspective, I guess, as a researcher, is it allows us to now go retrospectively back to completed clinical trials. We can then re-stratify based on anticipated baseline tau level and re-estimate effect sizes. And perhaps maybe we missed something before based on the underlying tau burden that wasn't assessed. I have to thank my grad student at Berkeley, Marcel. He did all this work. The preprint's here, so if you're interested, take a look. We just revised and resubmitted this morning. So thank you.
Amazing work, Joe.
Oh, thanks.
Do we have any questions? We actually do have some time for a few quick questions.
So you're showing the lateral temporal as being severely involved, as opposed to the medial temporal neocortex. Is that correct?
I think that that's maybe a distraction of the surface-based rendering. I think if we were to look back in the voxel space, you would then see actually the signal you expect in entorhinal and hippocampal signal. One thing, though, is we built it to predict flotaucipia, where the hippocampal signal is not very good because you've got choroid plexus next to it. So there is medial temporal involvement, and the JAK metatemporal region of interest takes that into account. But yeah.
Okay.
Joe, is there a simple underlying biological story here? I mean, are you accounting for all the covariates and then looking for a cortical atrophy of a particular pattern?
You have to use a microphone.
I could hear what I was saying. Is there an underlying neurobiological story here? I mean, after accounting for all the covariates, the age and the other potential forms of neuropathology, are you modelling the underlying cortical grey matter loss, or is there some other magic in the mix there?
Who knows what deep learning's doing, basically. It could be doing whatever it wants to do on the day. My idea and thought of it is it allows you to put everybody in a straight line, and it says that this person is most similar to this person, and this person's tau PET was this, and the person next to him's tau PET was this. And so effectively it's a way of just modelling those latent relationships, ranking people, and then projecting out into the anticipated tau PET. So it's everything and nothing at once.
I feel like you're cheating a
I am a
little
little
bit
bit cheating.
because it's info, but thank you, Joe. It's really remarkable work. Our next speaker is at the coalface of cognitive assessment of people on the journey of dementia. She's a clinical neuropsychologist. She has a PhD in neuroscience. She's also managing and running clinical trials. And working together with myself, you know, like many of us in this disruptive field, we encounter all these tectonic bursts through what we're doing and what we've been doing and what we find we should be doing. So I'm very pleased that Renate is going to begin unravelling some of the disruptions to diagnosis that have followed breakthroughs in biomarker development. Thank you. Renate, who's also from Newcastle.
Just check out. Okay, have a look. Would you mind changing how you display this as well, so I can see it a little bit better? Thank you very much. Right, then I actually don't need my glasses anymore. Okay, thank you very much. So Aboriginal and Torres Strait Islander people they are the first scientists and they are the first bearer of all knowledge. And we are paying our respect to the EORA people for welcoming us here and running all our sessions here on their land. And we're also paying our respect to people from the area where I work on, which are the Awabakal and Worimi people. And I would also like to make sure to mention that this has been and always will be Aboriginal land, and also draw the attention back to the fact that we have highly increased rates of dementia in First Nations people, and this is largely driven by social determinants of health. I would also like to thank and acknowledge people here in the room who have lived experience of dementia. I would like to thank the organizers to invite me to talk about diagnostic criteria, international recommendations, and versus current practice. And what I'm presenting is largely based and thanks to our involvement in Newcastle with EdNet, running the clinical trials and the trials and screening arm there. So we are currently definitely at a very critical inflection point where it becomes even more important to early diagnose people as early as possible because of the increase of disease-modifying agents that are now available, and because we know that treating early is very important. And therefore, using potential biomarkers that are already on the market or will be on the market very soon to diagnose before cognitive impairment is accessible. But where are we now? So we're still diagnosing at the moment using the DSM-5. So this is the American Diagnostic and Statistical Manual in its current version that we're using. And you can see dementias are part of the so-called neurocognitive disorders. And if you look through the criteria there, they are all clinical criteria. So we have no biomarkers there at all. That's the base neurocognitive disorder. One step further, the additional criteria for specific AD, again, completely clinical. So it's a clinical syndrome that we're looking at. The next step when you go through the DSM, where it branches out into probable versus possible AD, again, apart from genetic mutation or family history, it's solely clinical. And what happens then if somebody sees someone and does a diagnostic workup using the DSM, then there might be a decision made, we should potentially use also some biomarkers, but that is largely dependent on funds. And I've just plotted here the funding situation with newer biomarkers, including blood biomarkers. You can see that the costs vary, and the costs are quite high when compared to an FDG PET or a CT brain. When we're looking at the second gold standard, the European classification system, the ICD-11 as in its current version, it seems to be quite beneficial that there is this distinction between the preclinical and the clinical Alzheimer's disease. So on the left side, we've got the dementia due to Alzheimer's disease, and largely the criteria that you can read through there, they pretty much mirror just the DSM-5 criteria. It's clinical syndromic still. But there is this alternate or this distinct diagnosis, the Alzheimer's disease diagnosis. But I was mind-boggled when I actually looked a little bit further into it that there are no criteria under this. So we've got those two distinct diagnoses there, but we have no criteria to diagnose it using the European classification system, which otherwise looks a little bit ahead of the DSM-5. And then we're looking at current international recommendations. So these international recommendations, they have developed over the last years, and the most recent one is from 2024, from Jack et al. And they clearly define AD as a neurobiological construct. And that looks like this. Alzheimer's disease is defined as a biological process that begins with certain neuropathological changes whilst people are still asymptomatic. Then so-called core 1 biomarkers, which include amyloid PET, CSF, and p-tau217, are defined, and they are regarded as reflective of this AD neuropathology. And those core biomarkers, if abnormal, they then can result in a diagnosis of AD. When you read a little bit further in that document, however, it states that they, at this point in time, should still not be used solely to diagnose. And then there are the so-called later core 2 biomarkers, including tau PET, which can be used for staging, prognosis, and supporting the diagnosis. And then the Alzheimer's Association accordingly has developed clinical practice guidelines on the use of blood biomarkers, and they are quite recent, as you can see. So all these recommendations, they are in regards to people who present with actual cognitive deficits, for instance, to a memory clinic. Recommendation number 1 is for triaging people. And the recommendation here is to use high-sensitive blood biomarkers, and the sensitivity should be at least 90%. And a negative result would then rule out AD pathology. A positive result still needs confirmation. Recommendation 2 for a confirmatory diagnosis, again looking at patients with objective cognitive impairment, where a negative result would rule out AD pathology and a positive result rules AD in. And then as a general good practice statement, the association still claims that you will still need to have a comprehensive clinical evaluation even if you do have sensitive blood biomarkers. And for some reason, So wouldn't it be fantastic if we would very soon have the next iteration of, for instance, the ICD, which could be the ICD-12, where we have a distinction between preclinical and clinical presentations and are actually enabled to diagnose. And that would mean that we would need to be able to define the pathology and define that Alzheimer's disease diagnosis by its pathology. We need to define the pathology through specific characterizations. We use core features of it. We still look at clinical presentations. In that case, that will be preclinical. And we incorporate the clinical presentation with biomarkers, imaging, and other pathology readouts. So in our group, what we were looking at is that there seems to be this big gap between the recommendation and what the clinical practice looks like. And this big gap was also experienced in our group when doing research. So the gap seems to also translate into research. And this is where our group has started to prepare a perspectives paper, which we just have submitted in Alzheimer's and Dementia. And in this paper, we're looking at potential changes of motivations in people who come on board with clinical studies, like the ones that we are running. So in those research studies, usually when you see people, initially the motivation might be largely, or the majority might be quite altruistic. So the motivation is more like contributing to science, and a smaller fraction of our participants would already come into the studies looking at health monitoring or hope for intervention. And this will then change at, we call it divergence point. As soon as amyloid beta is disclosed to those participants, the motivation might change. So more of the contribution to science fraction might move more towards like a less altruistic and more health monitoring motivation. And this motivation, again, might change depending on whether or not that person is eligible to go into a clinical trial. So to sum this up, there's a lag between international diagnostic recommendations and current practice, and surely also between recommendation and research. Biological definitions of AD are increasingly endorsed in research, not so much used in practice yet. Biomarker disclosure currently occurs in research, and again, not very often in routine clinical practice. And there are gaps between pathology knowledge, treatment availability, and patient support pathways that we still need to work on. I'd like to thank our group, and I would also like to point your attention to the memory and cognition clinical guidelines developed by ADNET. If you want to use your phone, you can use the QR code. They're really very helpful. Thank you.
Thank you, Renate. That brilliantly highlights the fractures and frissions in our field. We probably have time for one burning question, otherwise maybe this is a good topic for the end of day drinks. Okay. Renate will be at the drinks, so you can talk to her. I now have great pleasure in introducing Professor Kaarin Anstey. Many of you, or most of you will already know Kaarin's internationally groundbreaking work, and she's the director of the UNSW Aging Futures Institute and an ARC Laureate Fellow. So thank you for giving us a sort of slightly different perspective on this interesting topic, Kaarin.
Good afternoon, everyone. Thank you for hanging around for this talk. I know it's getting late in the day. I'm going to talk about the preliminary results from a remotely delivered, low-intensity, multi-domain risk reduction intervention called MyCoach. We conducted this trial during COVID, and this is part of the Worldwide Fingers Network, and this is just the preliminary results. We haven't finished analysing them. So, as you all know, there are gaps in services for people with mild cognitive impairment and subjective cognitive decline. We hear this from GPs in particular and from the general community. And some of the packages that are available are not necessarily evidence-based, so they're not necessarily based on clinical trial research for effectiveness. Often in-person interventions can be expensive and they're not accessible to people who don't live close to tertiary sort of teaching hospitals and research settings, or they're quite expensive for people who have to travel. And the successful interventions that have been developed for people who don't have cognitive impairment are not necessarily suitable for people with mild cognitive impairment, and we found this through our own research. And until now, there has been no fully remote, multi-domain risk reduction trial for people with mild cognitive impairment or SCD. So the trial that we developed, the intervention was called MyCoach, and it was based on about 15 years of research from my group, where we've conducted a number of multi-domain interventions using initially hybrid methodology. We'd have an e-learning course, and then we'd have participants see an exercise physiologist, for example, in person. We've conducted research in primary care with GP practices. We've conducted a scoping review and worked with consumers to understand what sort of interventions they would like and whether they're interested in digital risk reduction interventions. And that all led to an initial study that we published where we did find a significant benefit of our earlier intervention called Body, Brain, Life, and that was for people with mild cognitive impairment and SCD, and we found an improvement in ADRS-COG over 6 months. Over the years, we've found we've had to really adapt how we develop our interventions for people with mild cognitive impairment. We reduced our e-learning course from 8 modules to 6. We have memory aids that we use during the study. We have a lot more research assistant support, and we have clinicians and referral systems in place. We have a subgroup who always have a lot of difficulty with technology, so we plan for that and we support those participants. We use quite simple goal-setting approaches. So when we started off, we were using good theoretically grounded psychological approaches, behaviour change wheels, etc., and we found that they didn't work in this population. We now use simple goal setting. We have developed videos that we employ professional actors who normalise having memory loss. We talk about living with memory loss, and those actors also do role-playing of how to solve problems. That's all the adaptation to our trials. So coming on to MyCoach, it was a 2-arm, single-blind, randomised controlled trial. We had 326 participants, aged 65 and older, with memory concerns. People recruited online. Remember, this was during COVID-19 that we started the trial, and most of it was conducted during COVID. It was digitally delivered using e-learning, consultations, brain training, targeted exercise, diet, stress reduction, and social and cognitive stimulation. The control group receives the same information in email bulletins. They don't have any behaviour change intervention. They don't see any allied health professionals. The primary outcome from the trial was the ANU ADRI at 12 months. Secondary outcomes were cognitive function, and then we looked at the different components of the intervention: physical activity, diet, and cognitive training. And we collected data at baseline, 13 weeks and 6 and 12 months post-intervention. We conducted, as I said, the entire trial was conducted remotely. So, for example, we had a neuropsychological assessment conducted through Zoom, which was similar, follows the finger trial in terms of the tests that we used and the domains that we assessed. The intervention components, there's 4. We have e-learning, we have brain training. We use Brain HQ, which has the most evidence in support of it in terms of brain training for people with MCI. We have dietitian consultations with a dietitian over Zoom, and exercise physiology, which is the consultations are done over Zoom. The e-learning modules were designed to be very familiar. They're actually based on another trial that we worked on actually with people with early dementia. We use familiar icons and guidance pages throughout. There's reading and listening, but there's also optional interactive activities to work through some of the material. There's reflective questions, self-directed goal setting, and then we have the videos that I mentioned earlier. Okay, who was in the trial? So we had participants from all over Australia. Every state and territory. It was a national trial, and this is going to challenge my reading of the slide. We had the majority of people with we had 275 participants with SCD and 53 with MCI. We had just about nearly a third of our participants from regional and remote areas, which was what we wanted to achieve with making the trial and the intervention accessible to a wide range of people, and the average age was about 74. Okay, so we got a main effect at 3 and 6 months, which means both groups improved in their annual ADRI, but we had a significant group by time interaction at 6 months, which was significant at less than 0.01, which means our trial was successful at 6 months, but the effect wasn't maintained for the full 12 months, so it was no longer significant at 12 months. This shows you the main results. So group A is the intervention. In terms of subgroups, this is very preliminary results, but we had significant effects in the older. The trial was more effective in the older participants, over 75, and it was more effective in men than women. We had very high adherence. We found with our previous trials in this population, and with people with MCI who come into our trials, they really are very motivated. In our BBLCD trial, we had 100% adherence to e-learning and consultations. In this trial, we had 83% of our participants completing 5 or 6 out of the e-learning modules. Just show you the individual session completion. So exercise physiology, the first session we had 95.9%. Dietitian, 98% completed their first module, 83.1% did the booster session, and we saw improvements in the cognitive training when we analysed that as well. The strengths and limitations. It was national. We've shown that you can do this. This is a model for delivering a service which works and which was very positively received by patients and the community. We had very high adherence and retention. We had a good effect at 6 months, significant at less than 0.01. The problem with our trial was we did not select on risk factors, and we ended up with a large number of worried well, which limited our capacity to get a significant effect statistically. And so the positive effects were also not maintained at 12 months, and so we wanted to strengthen the intervention. We have another trial underway funded by MRFF, which we've built on from that MyCoach trial. It is another national, fully online trial. It's going to have about 660 participants. It's been co-designed with consumers. We're recruiting from primary care, ADNET and the community, and we have changed our selection criteria to be much more rigorous for SCD and MCI. We have an informant interview. We have a stricter requirement on risk factors, and we've increased our intervention strength. We have brain training now for 12 months, and more booster sessions, a lot more intervention in the second 6 months. I'd just like to acknowledge my funding and my wonderful team who worked on the trial. Thank you.
Amazing retention and completion rates. Any insight into what motivated people to, continue through the program?
As I said, I think this is a very motivated group, people who come into a trial concerned about their memory, but also even though it's online, it's a very personalised experience. We try to keep the same research assistant for all of the interaction with each participant, so they build that relationship. And then we have, with the rural and regional people, they don't have any other services. So it is really filling a gap.
Thank you, Kaarin. Yes, one question.
Michael Woodward, you're aware of Henry's slip, slop and slap dementia program. I mean, haven't we got beyond the stage where we need to do more trials and we just need to do it?
Thanks for that question. This is a trial is not a trial of the general community. So the slip, slop, slap is about population risk reduction, brain health in the whole population. This is about offering a service for people who have MCI or SCD who come to their GP who currently have nothing. So it's filling a different gap in the universe of dementia diagnosis and treatment. So ultimately, I think this sort of program will be alongside, you'll prescribe a medication, and then your patient can do some e-learning, which gives them a lot of coping skills, teaches them how to manage their memory and about how to manage their risk factors.
Henry, you have a comment on the comment?
Henry, yeah. It's fantastic work, and I think we do need multiple approaches to see which one's working.
Yeah.
And I mean, Kaarin's co-investigator on the Maintain Your Brain trial, and so we've worked together for a long time. I just wonder about the workforce implications, how much it costs if we were to roll something out like this.
Yep. Well, for this trial was done during COVID with minimal grant funding. We are not doing health economics on this grant. We actually did our health economics analysis on our trial, which we did in 7 GP practices, and that was cost effective. But we do have a very in-depth cost. We've got a health economist working with us on our current MRFF-funded trial. And it's digitally delivered. So all of the e-learning, now that it's written and developed, that's done. That costs, and we do it on Moodle, so that's almost nothing except hosting. There's the allied health consults, which we think we can get those through an MBS item, a chronic disease management item. So then you do have the brain training license, which is, you have to pay for that. So we think a lot of it can be mopped up in current items, but there would be a small cost. But when you compare that to some of the health, preventing chronic disease and delaying dementia onset, it quickly becomes cost effective. Yep.
Okay, thank you very much, Kaarin, and that wonderful work. Continuing our pivot from diagnosis to treatment, back into more pharmacological mode, I'm very pleased to introduce Paul Yates, who's a geriatrician, a Director of Research at the Austin Health Cognitive and Dementia and Ageing Institute. And Paul will be talking about implementing and rolling out some of the disease-modifying therapies. Thank you, Paul.
Thanks, everyone. True to form, have put in far too many slides. I'll talk incredibly quickly. If you need to ask questions at the end, I'm happy to go back and speak more slowly at the reception. So this is a bit of a pivot to now and in the future, what we might be prescribing. Here are my disclosures. And it's really exciting. I think we've seen some great presentations today about diagnostics and in different other interventions. I'm going to focus on the drugs to begin with, and we can see that the pipeline is really rich, and it's been growing year on year in terms of the number of drugs in clinical trials for Alzheimer's disease. And these are new and repurposed in many different mechanisms of action and different phases as well. The therapeutic targets, which we've seen, and many people have seen versions of this slide before. For Alzheimer's disease, there are many potential targets, including particularly targeting beta amyloid, but targeting tau, targeting the neuroinflammatory processes, and other neuroprotective mechanisms as well. Let's not forget cognitive enhancing and symptomatic therapies and treatment to manage later stage symptoms as well. In terms of the amyloid targeting therapies, there have been a number of monoclonal antibody therapies targeting different stages of the amyloid cascade. And you can see here from the anti-oligomer, sort of gantenerumab, solanezumab, crenezumab, through to protofibril targeting drugs like lecanemab, through to the plaque. So I don't know what you just did, could you bring back the main slide? Thank you. The plaques, like donanemab and renatide. And many have asked, and there was a recent Cochrane review saying, do these drugs actually work? Well, this is a slide courtesy of, that's been provided courtesy of Lilly, but we know that these drugs, when you put together the whole lot, probably if you average them out, you might find in a Cochrane review that they are less efficacious. But if you look at those that actually are lowering amyloid substantially, that's the group of drugs that have been successful in their trials and are showing a shift in terms of their cognitive impact. So the bottom left are donanemab, lecanemab, and aducanumab, those who are actually achieving some amyloid lowering, and the top right, the crenezumab, the solanezumab, are those who really didn't shift the cognitive endpoints much. So we have two drugs that are approved in Australia now. So donanemab, as I mentioned, that targets the fully formed plaques, and we know we've seen some of these data already. The overall population slowing of decline in about 22%, and CDR sum of boxes 29%. And when you looked particularly at those with MCI or low-medium tau, that the impact certainly seems a lot more impressive. So 60 and 46% slowing of decline in those sort of subpopulations. And we know in donanemab also it lowers amyloid profoundly, and as we've heard presented earlier today, it could achieve amyloid clearance in a high proportion of people within 6, 12 or 18 months of therapy. We've seen the long-term data presented already, but the main point from this slide is that the treatment benefit tends to extend beyond the 18-month trial period and show a disease-modifying effect. In terms of safety, main side effects include ARIA and infusion reactions. And the second drug I'll talk to now is lecanemab. So that's the pyroglutamate, the protofibril form of beta amyloid, and that showed from the Clarity study a similar sort of 27% slowing, which was more profound in the earlier biological disease stage and clinical disease stage. It similarly had a very potent effect on amyloid, and the clinical outcomes continue to show a widening difference through open label extension to 48 months. Most common adverse events, again, infusion reactions and ARIA. And when you look at the two sort of next to each other, not head to head, but next to each other, you can see that particularly in ApoE4 homozygotes, the rate of ARIA goes up, and the Trailblazer ALZ6, which is the modified titration, which has been implemented in Australia, shows a much more favourable safety profile. So those are what we know. What's coming next? There are a number of amyloid targeting monoclonal antibody therapies that are in trial as we speak, including remternetug, which we've heard a bit about today, trontinemab, Thienel, which has had its production, so its pipeline paused, but being redeveloped with a transferrin receptor and a new anti-A-beta 42 Lilly compound as well. So remternetug, as we've heard, it's another anti-plaque monoclonal antibody, which is very potent in terms of clearing, and as we've heard today, every participant cleared at the high dose within 3 months. That's 3 doses, and it's currently in trial in early symptomatic Alzheimer's disease, with a completed trial with a readout coming soon, and the phase 3 MCI preclinical study ongoing. Trontinemab, that some reason has been cut off the slide, trontinemab, is a Roche product which shows great potential as well at potently lowering amyloid, using a novel shuttle transferrin receptor to actively transport the medication across the blood-brain barrier. And we know that it can achieve much higher concentrations within the brain compared with its predecessor, gantenerumab. It's been tested in phase 1b/2a dose escalation study, and that showed really robust amyloid lowering in a dose-dependent fashion, again within a couple of doses. So it's really exciting to see this next generation of medications. In terms of where next for these drugs, we're seeing them now move into the preclinical phase. So we've already heard a bit about Trail Runner. There's also Trailblazer 3, which is aiming to have a readout potentially earlier, but as at some stage at the latest 2027. There's the AHEAD A345 study, which is in lecanemab in preclinical Alzheimer's disease, and we're expecting a completion in 2028. And soon to be opening is the preclinical trontinemab study, so Preventron, which is hopefully going to be launching towards the end of this year. So that's really exciting for people who are concerned about their future risk and already doing all of the disease-modifying lifestyle interventions, but still might remain at high risk. The other things we know are tau targeting therapies have been trialled, and there have been a number of not successful vaccine and tau targeting antibodies, for example. Most recently, we've had bepranemab, which has had a phase 2, which was negative at its primary endpoint, but it certainly does have an impact on tau accumulation, and that may be going forward to a phase 3. Posdinemab, or the autonomy study, so that was a negative phase 2b for its cognitive endpoints, but again, it did fully abate some of the biomarker changes, so we saw a robust lowering on the p-tau217 biomarker. E-size E2814, which targets which has been shown to lower CSF microtubule binding region tau by up to 75% in dominantly inherited Alzheimer's disease patients, and it's ongoing in an open label in the DIAN study. So this is an open label study, and people with dominantly inherited Alzheimer's disease, it certainly does potently lower the CSF more advanced versions of tau, and that's being tested in a combination trial in Japan and the US in combination with donanemab as well, so as an add-on therapy. So you can see these are in the DIAN patients. We've also got currently in trial recruiting in Australia. We have the MK2214 Merck drug, which is in phase 2, and the Janssen phase 2b, which is closed for recruitment, which is a vaccine. Going very quickly, but neuroprotection. So this was a medication which has had a bit of controversy, blarcamazine. It's a small molecule agonist, sigma-1 M13 muscarinic agonist, and it certainly had some promising results from its phase 2b/3 study. It did have some significant outcomes on some of its clinical endpoints, and it launched an application to the European EMA in 2024, but that's now been withdrawn, and so we're yet to hear where this drug is going to go next, whether it's going to be retested or the data is going to be reviewed. In terms of others, there are various mechanisms that are really showing some great promise. There are antisense oligonucleotides, such as the Biogen Celia study, which is an intrathecal medication, which on its phase 2 did show some slowing of cognitive decline and reduction in CSF tau and tau PET signal, and that's planned for a phase 3. There's the actinogen Xanamem compound, which we're expecting some of its phase 2B and 3 top-line results later this year. Probucol, which is in trial as a repurposed cholesterol drug. Tasbentadol, which apparently regrows synapses, which has had promising phase 2 data presented in the last 12 months as well, and it's being tested in motor neuron disease, schizophrenia, and glaucoma. And the Novartis TREM2 agonist that stabilizes microglia, so that's ongoing as well. And as well as the disease-modifying therapies, we have a lot of trials going on for cognitive enhancers and symptomatic therapies, including the Mindset trial of CAR-XT, which is a muscarinic medication, and Canoxus, which is a symptomatic treatment aimed at the more severe symptoms such as agitation. And as I said, I haven't got the time today to talk about non-pharmacological management, but it's so eloquently already been covered, and prevention and multi-domain interventions. So we may be seeing this new era in targeted treatments for biological stage, where we might have, of course, exercise, risk management, cognitive stimulation, sleep and mood across the lifetime, gene therapies, antisense oligonucleotides, amyloid and tau vaccination, anti-inflammatory, amyloid targeting therapies, tau targeting therapies, and neuroprotective therapies, and then symptomatic therapies across the life course, I guess, of the trajectory of illness to really protect our brains in different ways. So this is my last slide, or close to last slide. So we're seeing a really exciting era with now biological staging. We're seeing new therapeutic mechanisms. We're seeing prevention trials, novel symptomatic treatments, personalised treatments, combination therapies. I did this slide once when I was very tired, and they're playing treatments for non-Alzheimer's disease dementias on the horizon. If you'd like to learn more, I'll be talking a bit more about our community of practice, the ADNET community of practice, on Wednesday. It's a group of people who are interested in learning more about new innovations in dementia diagnosis, treatment and care, not just drugs, but care paradigms. We'd love to have you join and come along to our meetings or suggest content and advocacy. And I'd like to say thank you very much to be invited here, and to our teams for supporting all of the work. Thank you.
Thank you, Paul. So we've really covered a breadth of breakthroughs in diagnosis and treatment, pharmacological, non-pharmacological. It almost looks like a great time for the Australian government to get really ambitious about funding the future of dementia research in Australia.
Is there anyone in the room?
But it's also looking a lot like a lot of other complex and molecular disorders. There should be some questions, I'm sure.
I'm standing between people and
Yeah, but
drinks.
look, there's standing room at the back. I'm very impressed. Okay, well, there is drinks coming up. And Chris Rowe and the City of Sydney have co-sponsored a light show tonight, also known as Vivid. So that's brought to you by ADNET and the Australian government. So when you see the fireworks, there was a drone show that looked a lot like the misfolding of amyloid. And as a result, a lot of the drones fell into the Darling Harbour last week. And that's been kabooshed, but I'm sure there'll be lasers and fireworks and a whole lot of other stuff. And you can thank Chris Rowe and ADNET for the light show. I'd like to thank our 4 speakers in their contributions this evening, and thank ADNET and the other sponsors for ADRF, and Alita and Sheree for organising it. And now encourage everybody to enjoy drinks, which starts at 6 p.m, I believe.
Another session.
Oh. I'm sorry. I do everything on the fly here. Oh my God. All right, I'll be buying drinks for the next speaker. So please don't go and enjoy drinks, but stay and enjoy our next keynote speaker.
very specific. 1 minute to go. All right, I think we're almost ready to start. I think there's a short video that's going to play first from our sponsor, Dementia Australia.
You'll get better when you're not blamed for a condition you can't control. You'll get better when your care doesn't depend on your income. You'll get better when your pain isn't minimized, dismissed, forgotten. We will never stop trying to get better. Because when medicine gets better, all of us can get better.
Great. So, welcome to the last session of the day. My name's Michelle Calasire. I'm a Professor of Physiotherapy at the University of Tasmania. It's my great pleasure to chair this EMCR Rising Star Keynote session. I'd like to introduce Dr. Claire O'Connor. Claire is a Dementia Centre for Research Collaboration postdoctoral fellow, Senior Research Fellow at the University of New South Wales, Conjoint Senior Research Fellow at Neura, and Honorary Senior Research Fellow at Hammond Care, and a Registered Occupational Therapist. That's a very long sentence. Claire leads a program of research focused on translating evidence into practice to improve the lives of people living with dementia and their care partners, and her work focuses on rehabilitation, reablement, and supporting people with dementia to maintain function, independence, participation, and wellbeing following diagnosis. I'm sure this is going to be the best presentation of the day. Welcome, Dr. Claire O'Connor.
No pressure, and some people thought that there were drinks before this. Thank you very much, Michelle. Okay, and thank you so much to the Australian Dementia Network, the ADRF Program Committee, and the EMCR Accelerator Group for the opportunity to stand up here today at ADRF and talk about dementia rehabilitation. This is a massive honour, and I'm extremely grateful for the opportunity. I would also like to acknowledge that we're all meeting today on stolen Gadigal lands. I recognise the continued connections to these lands and the waters as well, which we can now see. And also that sovereignty was never ceded. So I'd like to pay my respects to the elders past and present and extend that respect to any Aboriginal or Torres Strait Islander people who might be joining with us today. So by addressing 14 risk factors across the lifespan, there's potential to prevent or delay nearly half of dementia cases. I know this is not new information to anybody here, and this is not the first time even today that we've seen this graph. But it is important because we are now at a point in time where there's potential to look at prevention and delay of dementia. So the scale up of risk assessment and risk reduction interventions is absolutely a vital opportunity that must be harnessed. But in all the excitement of risk reduction, we must not forget that there are more than 55 million people currently living with dementia in the world, and almost 500,000 people living with dementia currently in Australia. I'm not going to go into disease-modifying therapies today. There's heaps of other people talking about that, but I just want to say that the proportion of people living with dementia who are eligible for these therapies is currently very small. So this paper by Di Francesco et al. Estimates it to be about 4%. And while a lot of significant and important improvements have been made in this space, they're not without their controversies, as evidenced by the recent Cochrane review, which just came out. So ultimately, we've got quite a long way to go before we have broadly accessible and clinically meaningful drug therapies for people with dementia. So while we wait for these clinically meaningful and broadly accessible drug therapies, it's vital that we support the nearly 500,000 Australians who are currently living with dementia. And the National Dementia Action Plan has highlighted that we must improve dementia diagnosis and post-diagnostic care and support. So if only there was a post-diagnostic care option that had potential to benefit almost every person living with dementia. There is. It's called dementia rehabilitation or dementia reablement. And the National Dementia Action Plan specifically highlights that people with dementia should have access to reablement. And the 2025 World Alzheimer's Report was dedicated to dementia rehabilitation, defining it as a personalised, goal-oriented approach that addresses a range of needs depending on the person's preferences, strengths and difficulties. Let's just take a pause a minute to talk about terminology, because I've mentioned dementia rehabilitation and I've mentioned dementia reablement here. And the reason for that is because there's no global consensus yet on which term we should be using. So these are just a couple of examples of recent Australian studies where either term has been used to describe essentially very similar approaches to supporting people living with dementia to maximise their independence and participation in life. Internationally, there does seem to be a bit of a trend now towards dementia rehabilitation with the World Health Organisation and the World Alzheimer's Report. I wouldn't be surprised if that is where we end up. But in Australia, the government keeps using reablement. That's what all the funding is tied to. So there is still a bit of interchangeability at the moment in terms of which terms are getting used. So what's it all about? So there's some key principles involved. It should be person-centred and individualised. So focusing on what matters most to the person and what their priorities are and their abilities. It should be goal-oriented with function-focused goals, so specific, meaningful goals anchored in everyday life and participation. For example, supporting somebody to independently make their breakfast every morning. It should be strengths-based and capability-focused, so with a real emphasis on maintaining abilities for as long as possible and building on preserved strengths and capacities and habits, rather than focusing on declines. It should be collaborative, so it should involve the person with dementia, where appropriate and available, the person's family and the care team working together. It should be interdisciplinary and holistic, so it should be considering cognitive, physical, environmental, social and emotional factors together. And it should be considered across stages and settings. So because it's so individualised, what it looks like could look different for each person, depending on what their priorities are, their goals, their abilities and their context. These are some examples of what could be involved: cognitive rehab, or it might involve exercise. You might look at the person's environment. And when the family is around and available, they should absolutely be considered in parallel with the person living with dementia during that program. And it could involve any combination of these things as well, depending on what that person's goals are. I'm going to give a very quick example of how multidisciplinary reablement could look for someone living with dementia who wants to continue their favourite activity of gardening. So the occupational therapist might come in and look at how that person is doing that activity and might make some suggested strategies for how they can continue to do that safely. And they might look at introducing some supportive aids like a retractable hose or perhaps a raised garden bed to increase accessibility to the garden. The physio might come in and assess the person's strength and balance. Maybe they'll provide a mobility aid that's appropriate for the person to help them move safely, and maybe they'll provide fall prevention, education and strategies for the person with dementia and their carer. And then maybe an exercise physiologist will come in and look at providing specific exercises tailored to what the person wants to do in the garden, like bending, lifting and moving around safely. So the evidence suggests that people in the earlier stages of dementia are more likely to gain the most benefit from participating in rehab or reablement, but every person with dementia has abilities. So it's really important that we identify what each individual's abilities are and support them to use those abilities for as long as possible to participate. And these are a couple of Australian examples of where rehab or reablement has been implemented in different settings. So Professor Lindsay Clemson led implementation of the COPE intervention in community settings, and Professor Yunhee Jeon is leading the iCharp study, which is implementing reablement in residential aged care. So in contrast to drug therapies, it doesn't matter what type of dementia you have, and it doesn't matter what stage of dementia you're in, every person has potential to benefit from participating in dementia rehab or reablement in some way. So what does the evidence say? Exercise can improve physical functioning and falls prevention. Exercise can delay cognitive decline and reduce behaviour changes. Cognitive rehabilitation can support people to continue doing the things they want to do. Occupational therapy can improve the quality of life of the person living with dementia, reduce behaviour changes, and support the person to continue participating in their daily activities. Occupational therapy can also support the quality of life of the family carer, reduce perceived time spent caring for the person with dementia, and reduce distress around behaviour changes as well. And speech pathology can support people in their communication and social connectedness, among other things as well. And the research into dementia rehabilitation has been growing at a rapid rate. So this graph just illustrates that growth from 2000 to 2023. And in 2023, the World Health Organization released a package of interventions for rehabilitation with a specific section on dementia. In 2024, we had the National Dementia Action Plan released, highlighting that people with dementia should have access to reablement. And in 2025, we had the World Alzheimer's Report dedicated to dementia rehabilitation. In parallel, there are practical resources that are available, that are freely available, I should say. So to support allied health practitioners and others to be able to design, deliver and evaluate evidence-informed reablement programs, and an e-course available through Dementia Training Australia on Introduction to Dementia Rehabilitation. So there's evidence highlighting the potential benefits of these approaches, there's resources to support it happening in practice, and there's policy that says that it should be happening. But people living with dementia in Australia are still not routinely offered dementia rehabilitation and reablement. A massive implementation gap still exists. And this is a human rights issue. So we know the potential benefits of these approaches. We know that people with dementia want access to these approaches. And the United Nations Convention on the Rights of People with a Disability specifically highlights that people living with a disability, which includes people living with dementia, have a right to early access to comprehensive rehabilitation to support them in maximising their independence and participation. Australia is a signatory on this convention, and the National Dementia Action Plan highlights that people should have access to reablement, but it is still not routinely offered. Why is that? To try and start to understand this question, Professor Kalasaya actually just recently led an MRFF study looking at the right to rehab for people living with dementia and how to start looking at addressing the stigma that's associated around this. One of the outcomes looked at barriers and potential solutions to address this. And barriers were identified at the user level, so lack of knowledge around dementia rehab and challenges navigating the system, and at the health service level, so low dementia knowledge of health professionals, negative attitudes of health professionals who still don't believe that there's benefits from people living with dementia to participate in rehab, and so that is a barrier to access, and then fragmented or non-existent services. A key solution that came from this work was around education and training, and that was across the board for people living with dementia and carers, health professionals and care coordinators. So one of the really important outcomes from this work was development of this Introduction to Dementia Rehabilitation e-course. It's freely available via Dementia Training Australia, and it's designed to raise awareness and introduce people to the concept of dementia rehabilitation and get people thinking about how they might be able to start rolling that out within their own service to increase access for people living with dementia. The research that was done around this e-course showed that the more people within a team that did the course, the more difference it was going to make in terms of actually changing practice. So the more people around Australia that we can get to do this course, imagine the difference we could make in terms of trying to reduce that implementation gap. So if you haven't already checked this out, please do. I've made it very easy for you and put a QR code there that will take you directly to the course, and please share it with your colleagues and friends as well. In parallel to Professor Kalasaya's MRFF, I've been working over the past few years with a team to also look at trying to understand this implementation gap and how we might be able to address it within this Australian context. We've been looking at doing a series of activities that have all been feeding into each other, and we've been working with an advisory group that's been really integral to providing really important consultation and input on the project. So the first thing we did was we conducted a clinical audit because we wanted to understand what happens for people living with dementia at the moment when they're referred for allied health support in the community. So we recruited 4 community aged care providers who provided us with data, and they were from different states in Australia, and they provided us with data from 20 people living with dementia. And we compared the data in terms of what allied health they received against the recommendations in the Reablement Handbook, which is pictured there. And then we fed this back to the allied health professionals from these providers in a series of focus groups. And we ended up speaking to 18 allied health practitioners. What we identified was that delivery of reablement between these 4 services, and even within the 4 services, was quite variable. And the allied health practitioners identified a range of barriers and enablers to implementing evidence-informed reablement in the community. Interestingly, they also identified a range of potential practice change targets where, on reflection, when reviewing the Reablement Handbook, they thought some of these things we could probably start looking at doing in our practice now. It was a small clinical audit. There was 4 community aged care providers. So the next thing we did was we wanted to look broader. So we conducted an international scoping review to look at barriers and enablers to implementing reablement for people living with dementia, and also looked at identifying implementation strategies as well. I don't have time to go into that right now, but it's freely accessible, so you can check it out yourselves if you're interested. So we used the clinical audit and the international scoping review to inform the next activity, which was a national Delphi survey. It was a 2-round survey, and what we wanted to identify was, in the first round, we wanted to gain consensus nationally around barriers and enablers to implementing reablement for people living with dementia. And in the second round, we wanted to identify some implementation strategies which were seen as being important and feasible to addressing the identified barriers and enablers. We had representation from every state and territory across Australia except for the Northern Territory for this one, and from a range of stakeholder groups as well. And we used a consolidated framework of implementation research to prepare for and evaluate the survey. So we identified a range of barriers and enablers across the system level, the service provider level, the family level, and the person with dementia level. So what you're looking at now are the barriers that reached consensus during the survey across those 4 levels. And so at the system level, an example of a barrier was not enough knowledge amongst the whole community, amongst referrers, which was really impacting on access, and that really parallels the finding from Professor Kalasai's MRFF work as well. At the service provider level, a barrier was around not promoting reablement to people with cognitive decline and dementia when they come into the service. At the family level, it was when families felt overwhelmed and not able to support the person living with dementia to participate in a program. And for the person living with dementia, living alone or not having family support was a barrier. More enablers and barriers reach consensus. So this is really encouraging because these are the things we can look at using to leverage to facilitate this and make it happen in practice. So at the system level, an example was having policy support. So where dementia rehab or reablement becomes an expectation for people living with dementia rather than something that's just nice to have or something that's extra. At the service level, it was about having multidisciplinary teams who are working really collaboratively with clear communication, top-down support, and who are promoting reablement to people with cognitive decline and dementia when they come into the service. At the family level, an enabler was understanding the abilities of the person with dementia so they can support them to keep doing what they're able to do for as long as possible. And for the person with dementia, the enabler was actually on the team. So making sure that the team took the time to develop a really strong rapport with that person with dementia to support them to participate effectively in the program. So the next round was about identifying implementation strategies, and we used the ERIC strategies list, or the expert recommendations for implementing change list, to help with this process. And we identified consensus for implementation strategies across 4 areas. The first area was around education for service providers, which again reflects on the outcomes from the MRFF project. And this was education around dementia and education around dementia rehab and reablement. These are a couple of freely accessible examples that we're suggesting people check out if they need to upskill in those areas. The second area was around planning for reablement implementation. So making sure that service providers understand there is adaptability in terms of how it's delivered and how it's implemented to fit within different service contexts. Making sure leadership is involved and that reablement is being promoted to people with cognitive decline and dementia when they come into the service. The next one had quite a lot of factors that reached consensus, and that was around practical considerations for delivering reablement. So examples would be supporting the person with dementia to participate effectively in the program, and when family is involved, supporting the family in parallel with the person living with dementia. The final area was thinking beyond the service provider, so thinking broader. So making sure that the people making the referrals and the diagnoses understand about dementia rehab and are introducing it with clients and patients early. Making sure that everyone's aware of the funding that's available and how it can be leveraged to support people to access programs. And the last one was about thinking about allied health teams more broadly. So Allied Health Professions Australia estimates there's about 300,000 allied health professionals in Australia. So if we were able to reach all those allied health professionals and upskill them a bit more in dementia and a bit more in dementia rehab to increase their confidence, it could really go a great way to reducing some of those barriers that people with dementia often face in terms of finding services. So everything that we've done so far has led to development of this new implementation guide. And the guide is developed to support service providers to be able to self-evaluate what their strengths are and to also identify opportunities for selecting some implementation strategies that fit with their service to be able to prepare for and roll out evidence-informed reablement for their clients living with dementia. So we're currently in the process of piloting this new implementation guide with some aged care providers in Australia, and we're using the Reablement Handbook as an example of a reablement intervention that could be implemented using the implementation guide. Taking a step back and looking more broadly again, another outcome from the MRFF project is this Dementia Rehabilitation in Australia roadmap, which is very newly printed for the first time just a couple of days ago. Hey. And it really just provides a really broad overview of dementia rehab in Australia currently, like which services are actually available, and then proposing what we need to do moving forward to make sure that there is equitable access to dementia rehabilitation into the future in Australia. If you would like to know more about this, please come and speak to Professor Kalasaya, or I know she's got copies to look at. I'm carrying around a copy as well if you want to hit me up to have a look. I'm going to use this opportunity to very quickly also talk about some other ongoing work that, in this space at the moment. Associate Professor Nathan Dacuna is currently leading an Australian Dementia Translation Grant, which is looking at developing a dementia knowledge hub, which is designed to be, or will be designed to be, sort of a one-stop shop where people with dementia, family carers and allied health professionals can go to access evidence-informed information about dementia rehab. It's still being developed, so we don't know exactly what it's going to look like. Dr. Sharon Savage is also leading a Dementia Australia translation grant, looking at translating Professor Linda Clare's great rehabilitation intervention for people with primary progressive aphasia. Dr. Mia Raj is doing a postdoctoral fellowship at the moment, looking how policies, funding models and service structures impact how people living with dementia access rehabilitation. And Associate Professor Jade Cartwright is currently doing a Churchill Fellowship, looking at supporting communication and connection in dementia. She's currently in Canada, I think, and she's doing a lot of posts on LinkedIn, so if you don't already follow her, check it out. It's really interesting, and she's posting about all the stuff that she's learning over there. There's so much more work that does need to be done in this space to keep this momentum going. And so it's an exciting space to be in, and I'm really glad that we get the opportunity to talk about it here at ADRF and hope that we can keep this work moving forward. And it's definitely something I think that we're stronger together in. So this is just an example from ADRF in Perth last year, where I think we're trying to take a really collaborative approach, and it feels like we're trying to break down silos and work together now. And there's many other amazing clinicians and researchers and advocates who aren't in this picture who are also doing such amazing work in this space. So everyone has a role to play in supporting the nearly 500,000 Australians who are living with dementia. So this is my call to action to all of you here. So if you're a diagnostician, please consider introducing dementia rehab to your patients early and support them in seeking this out. If you're an allied health practitioner, promote dementia rehab to your people with dementia. Use your full scope of practice to support people living with dementia. If you're a teaching academic, how can we introduce more dementia education and dementia rehab education so the next generation of doctors and nurses and allied health practitioners are all coming out speaking the same language to try and reduce this implementation gap? If you're a policy maker, how can we shift the paradigm so dementia rehab and reablement is an expectation for people living with dementia and not just something that's additional or nice to have. And if you're living with dementia or supporting someone living with dementia, please ask your healthcare team. Ask them for support in accessing dementia rehab. Maybe they can support you to find a cognitive stimulation group or a multidisciplinary allied health team who can support you in achieving your goals and participating in your life as best as possible. Thank you so much for this opportunity. I'm going to leave it there. This has been a real honour to be able to talk about dementia rehab at ADRF, so that's exciting.
Thank you so much, Claire, for that wonderful presentation. We have 5 minutes before drinks, so if anybody has any questions, please come up to the microphone and ask a question. I think everyone wants to get to drinks, but oh, yep, good, excellent.
Thanks, Claire. I'm Jo Trappier from Royal Melbourne Hospital. My question's around funding. What would you recommend if I wanted to set up a service? Where we would get this money from? Because I noticed barriers. One of the barriers was funding. I think it was 94% of people.
That's a great question, Jo.
Give us the good answer.
At the moment, people can use CHSP and hopefully they will be able to keep doing that into the future, but the government doesn't want that to happen. Watch this space. A lot of people are advocating for that to stay. Support at home should be able to be used to support people living with dementia, but anecdotally, I'm not sure how many people living with dementia are actually being referred for the restorative care pathway. If anyone's heard anything different to that, I would love to hear it. So I think there's a lot of barriers there in terms of people actually accessing the new support at home funding to access dementia rehab. Transition aged care is a good one for people who are leaving hospital to be able to access multidisciplinary care. It's a challenging space, and younger people can access NDIS hopefully to support them as well. It's an ongoing issue. I would love to hear, if anyone else has any thoughts around this, I would love to hear it. And there's a Senate inquiry at the moment into the support at home program. So if anyone has anything specific to say about people with dementia accessing dementia rehab, come and speak to me because we're putting together a submission, and I would love to have any input from anyone who's got any insights on this so we can try and change whatever's happening or not happening at the moment, so into the future people with dementia are referred for dementia rehab and can access that restorative care funding to access these programs. Thanks, Jo.
I just have one question. People around Australia are still excluded from rehabilitation in community rehab units, and I wondered what your thoughts were on whether we almost need a top-down approach to that, whether it's government or at health services to make it happen.
I think it needs to be like across the board. I mean, if I'm using my implementation science hat, it's everyone you have to bring everything together at once, but absolutely you need that top-down. I think it needs to be mandated that people have a right to access. It's a human right. People have a right to access rehab. Just because someone's got a specific MoCA score or has something written on a page that says they have dementia, you don't know whether or not they can participate in a rehabilitation program, especially if they're supported to do so. So I don't know how we change that, but it's a massive human rights issue that we need to address, and I think we need to try and, if everyone did the introduction, it was mandated for everyone to do the introduction to dementia rehab course across all the, the health courses and across the allied health peak bodies. They mandated that everyone had to do this for registration or something. Maybe that would go some way to support that. Maybe the government mandated that people delivering support at home and transition aged care and all those programs had to do the introduction to dementia rehab course. Maybe that would be a way to sort of try and reduce that gap somewhat. It's a difficult space to make change in.
Thanks so much, Claire. I promise I didn't pay Claire to mention that so many times. Great. So maybe over drinks, people can discuss what you can do to really make sure that people have access. Claire, thank you so much for your fantastic talk. If you could please join me in congratulating Claire on her presentation. And we now invite everyone to the AdNet welcome drinks at the Exhibitors Hall. Thank you.